Hello, everybody. My name is Dr. Amir Abbas, and today we have our guest Dr. Haider Naqvi. He is a professor of psychiatry at Dove. Uh, Dr. Haider Naqvi is a professor and head of psychiatry at Dove University of Health Sciences. He has done master in clinical research from Aga Khan University and master in clinical trials from London School of Hygiene. He is a senior mental health researcher and published more than 70 research papers in peer reviewed journals. Additionally, he has several book chapters to his credit as well. Um, so, what we can say is that he is a very senior mental health researcher, and today we are going to talk about different aspects and methodological issues in mental health research. So, first of all, Dr. Heather, thanks a lot for giving us time for this talk.
Thank you, Amir. I'm glad to be here, and I really have to appreciate the work you're doing. As just we were discussing before going online, that COVID has been a tough year. Everything has been like shut down because of COVID, and there's a lot of activity through tele and technology. And once you have to do research, do protocol and thesis, then these sessions and chats and discussions become the lifeline. So, all the best for the future. I'm glad that you're organizing these sessions.
Thanks a lot for these nice words. And I will go directly into our topic because our topic today is mental health research. So I'll go directly into my first question is that how health research is different from other researches? How mental health research is different from other researches?
It's a bit misunderstood, like mental health in itself. I mean, as far as I'm concerned, I do not accept this dichotomy that clinical practice or discipline itself is different from research. I think whatever you do is based on research, even if a physician is prescribing fluoxetine for depression or any antibiotic for infection for that matter, or vaccine is being like applied all over the world, that has stemmed from research. So we've come to a point where we cannot have this distinction. I mean, I see this as a schizophrenic science, or as you know, schizophrenia is mind divided. So we cannot have those disciplines that are split. Um, Things are moving pretty much towards unification of a lot of things. So mental health cannot be differentiated from research. Mental research is a bit different. It's more qualitative. Psychiatry in itself is a discipline that is more qualitative, it's based on symptoms rather than science. So once you come to research, a lot of it is like soft science, and it's more abstractions as opposed to public health research or quantitative research that is more outcome based. You have scales, you have lab measures, you have blood pressures. They're pretty cut and dried. There cannot be any distinction or argument related to or differentiation in terms of validity, in terms hard outcomes. But as far as the mental health is concerned, so you don't have that many hard outcomes. If you're going to assess depression, so you really need to quantify how you're going to measure depression, what scale you're going to use, and what is the sensitivity or specificity, whether you're going to have the same cultural construct as you have in the West. A very common example is you have this idiom. Their idiom of psychological distress, like somebody is tense and anxious, you would say, I have butterflies in my stomach. But you cannot literally translate to that, Pate mein titliyan hona. So those are cultural constructs. So individuals present with specific symptoms, and then you need to quantify them and measure them in a way that is translatable and that you can relate to other people. So it's a bit different. So you need to have some background understanding of mental health in general before you develop an understanding on mental health research. So it's a quite specialized area, but it's rewarding also if you get the hang of it. So it's like a really a virgin territory in terms of grants, publications, and non-communicable diseases. So I think young people need to be encouraged, and it should not be seen. In summary, it should not be seen in dichotomy with clinical practice or other disciplines. So it's a continuum. Somebody has high blood pressure, somebody has diabetes, so it cannot be differentiated from stress or depression for that matter.
Right. So I'm glad that you brought up a number of points over here. And before moving forward, I would like to go a bit deeper into these aspects. First of all, you said that there's no dichotomy, and like principles related to other fields of research is applied to mental health as well. And I'm good to take on that point in our subsequent questions or points. But here is the thing, like we talked about a few things. First of all, the cultural differences, use of different tools. Would you like to elaborate, like what do you mean by quantification or use of different tools in mental health research? Because I see those to be very much specific to mental health, as opposed to other disciplines.
Yes, I mean, you have there was this famous research that agreement between two physicians. You have this inter-rater and intra-rater reliability or reproducibility. If somebody is going to measure a blood pressure, say 10 at 10 a.m., then if it's produced after 5 hours or 10 p.m., would the finding be the same? So the reliability for psychiatric assessment in terms of syndrome is as low as zero point 0.4, the kappa statistics. Even with chance agreement, you have zero point 0.5. So that depicts that it's the construct. Schizophrenia is a major syndrome. Schizophrenia cannot be diagnosed through a lab test, or there are gene studies that quantify that there are certain polymorphism or mutations that signify, but it's basically empirical and research based, but it has not come to a point where it's used as a clinical diagnosis. So since the construct is subjective and the and it's more conceptual. The basis of psychiatry is based on phenomenology. It's a discipline of philosophy. It's the internal experience of an individual, how what they feel in terms of mental illness. So the distinction is not clear between syndromes. So somebody is feeling, you have low mood, you have jealousy in love, you have dysphoria, you have happiness, but where does it become pathological? So that has to be quantified through the classification system. Generally, we follow either DSM-4, that is an American classification, DSM-5, fifth version has come in, followed by American Psychiatric Association, or the ICD, the WHO classification. It looks to differentiate or quantify through descriptions. So those descriptions need to be elicited in an interview. It's not that you do a lab test and you'll have a diagnosis. The physician or a doctor will ask questions and the patient or individual will reply. Based on the reply, the physician will label symptoms, collection of symptoms that make a syndrome. So it's a lot of it is interview based. So and it has to be defined operationally. I can do a 1 hour interview and then diagnose someone with depression. But if you go into the epidemiology or the field studies, there are health workers and the data needs to be collected from a community. So you don't have an hour with a family or you don't have 2 hours to talk to the whole family. You need to complete the questionnaire in 10-15 minutes. That's why it needs to be shortened to a point where you have structured interview and interviews are illicit, are administered in a particular way. So this is what I mean when I say it needs to be quantified, and to quantify there are specific tools, and one needs to understand the scientific basis of those tools, how they're developed and how they implemented across time and culture. So each instrument has to be reproducible and it has to measure what it's saying it should measure. That's the validity. And then how sensitive it is and how specific it is. So unless and until you establish that in the native community, the results would not be valid. So it's important that healthcare physicians and mental health care physicians develop a sound understanding of principles of statistics and epidemiology. Something about epidemiology statistics that physicians are not very comfortable with it. I think it has to do with the undergrad education. So students need to be introduced to research and research methods from the start. At good places like Harvard or AKU, they have elective rotations during the second year, third year, fourth year. So students are exposed, and their interest is not in epidemiology or statistics. Their interest is in the question, the research question. So once you are driven by a question, then you're willing to eat the salad with the steak. So they develop an understanding of how things work in terms of statistics. So once they're exposed at undergraduate levels and they come into the residency programs or postgraduate education, they do not shy away. The general trend is if they're not exposed early, so the sort of maths, they're like turned off with maths and it becomes too anxiety provoking. So I think medical education needs to build in those research electives and courses. So once the students graduate, they're globally developed in terms of, you know, epidemiology, statistics, and basic science subjects that contribute to research.
Right. So, just as a reminder, if you have any questions, if the viewers have any questions, they can put them in the comments. We'll be taking questions in the end, if there are any, and I will move forward to our next point, and which I think is quite important. It applies to mental health research, but it also applies to any other research in health sciences. Is, for example, if my question is that if I am a researcher, I have to start a research work. So, how a research project should be started?
I think now you're coming down to the nitty gritty. Somebody starting research project should look at the major syndromes. Our general tendency is to go for uncommon areas and uncommon subjects. But the trouble with that is that you will have less literature in terms of where to start. And even if you find a novel drug or you discover a unique angle to a particular disorder, the impact would not be too much. So for beginners, and I've discussed this with some of my mentors and seniors also. So if you're into mental health research, I would say look at the common syndromes. If you're working at for major bread and butter is like depression, that's what psychiatry deals with, or psychosis, or mood disorders, bipolar, or anxiety disorders. So, given that, one should start with an area that is more common or prevalent. So, that will not only help you with getting a start on in terms of papers or established themes, but also if you discover something new, it will have more impact and you will have more publications for that matter too. There'll be more journal catering to it rather than if I'm looking at a very sub topic and or a very unique angle to a rare syndrome. So I would not have that public health impact or funding in itself. If I have found something and if I've published, then the next step is to procure a funding. Then I would like not have too many agencies supporting my work. So look for common things and develop a unique angle to them. And if you develop a unique angle, then of course you get a publication and things start from there.
Right. So, as you're talking about the common areas, and if we talk about population of Pakistan, India, Bangladesh, in that part of the world, so what are the common, or because you are a practicing psychiatrist as well, what are the most commonly prevalent psychiatric condition in the society on which, and that can also be the most active research areas in mental health in those areas.
Yes, it's a good question. I think the most common is the stress. It's prevalent. It's related to all the medical illnesses or the surgical complications and problems. Then, because of stress, anxiety and depression comes in. So prevalence estimates are as high as 30% or 40 or 50%, and then 2 to 4% has schizophrenia. Anxiety disorders are as high as 30-35%. So mood disorders are very common, and it has epidemiological map of most of the mood disorders, or for that matter, somatoform disorders, physical conditions presenting with psychological distress, in which there are no established physical disorders, but the symptoms mimic physical disorders, and it's purely because of stress, and we classify as somatoform disorders. Depression, anxiety, somatoform related to the stress are very common. So that is something that a lot of research have explored over the last 10 years. But even if you look at the Lancet series on mental health research published by Vikram Patel, I mean, they say that epidemiological map is almost complete. So what we need is intervention-based studies. So, what syndromes are understood in terms of etiology and descriptions? Yes, you have field trials in which the classification presentations are reviewed, but we need more intervention based studies. So, what works and what does not work in terms of addressing the problem. So, that is something that should be the focus in times to come.
Right. So you're talking about intervention-based studies, and for example, if I'm a researcher and I want to design my intervention, let's assume there's a particular behavioral therapy, say cognitive behavioral therapy, and I have to design it. And let's assume I want to do some kind of technological adaptation or want to make it available on internet. So how would you like how what are the steps would you recommend me to should I first study the CBT or behavioral therapy in detail, or should I design the technological aspects of it? Like, how would you suggest I should proceed in terms of moving forward
I
in
think
this?
it's a good questions for beginners, but since you are not a beginner and you already know the answer, and I know that you know, but still I would reply in a way that for a beginner, I think collaboration is most important. I
Hmm.
mean, if you're coming in as an expert or an expert in research or an epidemiologist or maybe an IT expert, so developing a team is the first part.
Hmm.
Um, Identifying the cause, this is important and this needs to be researched, or where I can get grants and publications. So generally researchers think of either completing the dissertation or getting the grant or publishing. So collaboration or building a team is most important. And you're right, even WHO has this, that developing countries have a lot of untrained manpower. So instead of producing lot of experts, the untrained manpower should be geared up, or their capacity should be built so that the interventions that are available and can be delivered at a mass level should be the way forward. Like in terms of CBT, cognitive behavior therapy, there are interventions, a short barefoot therapy, that 7-8 sessions intervention to minimally trained individuals, somebody who's done metric or just done intermediate, or they can read and write. They can be trained to deliver that therapy session by session. I mean, there are like 7 or 8 sessions, and each session has a structured format. So if you're trained that in that, then a team of like 10, 15, 20, 30, sorry, 30 field worker can be trained so that they can deliver, or it can be delivered through technology, through smartphones, through mobiles, so those things are also there, and there's a lot of funding potential with that too. So building a team, identifying a cause, building a team, selecting the intervention, and then delivering it in a way that is like cost effective, and it's clearly it gives robust results, would be the way forward. And this is the good thing with mental health, is that with little behavioral intervention, lot of morbidity and mortality can be reduced. I mean, some interventions can be, for some you need specific high cost intervention. It can be like interventional radiology, and for that matter, neurology also is technology driven. So if you want to establish a diagnosis or deliver an intervention, so some are very costly, but that is not so with mental health. With little cost, and so intervention can be delivered at the level of masses or public, and then the impact and reduction of stress, or the quality of improvement in quality of life, is tremendous. So there's a lot of scope with mental research, and those working in the area of non-communicable diseases, and funding agencies do recognize that, and there are calls given. But sadly, we don't have those teams where epidemiologist is talking to a psychiatrist and psychiatrist is talking to a psychologist, and both of them are talking to an IT expert, that how it should be channelized and how it should be delivered and how the training should happen. So once you develop a team, then yes, a lot can be done.
Right. So a lot of emphasis here in the discussion is on the team, but I have a very specific question which just got generated as a result of this discussion. Is that, for example, in if we are innovating a treatment for hypertension in the form of drugs, or there are regulatory bodies for that. I don't know exactly the name of that. I think that is DRAP or whatever that's called in Pakistan. But if I'm able to make a technological innovation in mental health as an intervention,
Mhm.
as being equivalent to say cognitive behavioral therapy, I mean, all speaking hypothetically, what are the regulatory mechanisms where I have to get it approved from?
So we are saying that there is an intervention that you're delivering through technology.
Yeah.
So yeah, so for example, cognitive behavior therapy is a psychological intervention that is delivered by psychiatrists and psychologists. It has this assumption that people have negative thoughts, or cognitive distortions, or they think in a way that leads to depressed mood, maladjusted behavior, or cognitive errors. The way they look at the world is a problem which generates stress, depression, anxiety. So if you correct the faulty way of thinking, then patients improve, their quality of life improve. So it's a short interview based, in which it's a talk therapy. A psychologist or a psychiatrist or minimally trained psychologist or a healthcare specialist, even a nurse or a healthcare work, community health worker can deliver that. So, in terms of delivering that, then if you have a psychologist on a team, then it can be delivered. If I am a psychiatrist, then of course I cannot lead a project on gynecology or gastroenterology. If there is an area it cuts across my interest, so then I need to have an expert on board. It'll be like foolish of me to assume that I will be able to technically supervise a project. So say if some intervention is being delivered, CBT, rational emotive, dynamic, insight based, or other forms of therapy, or a support group for that matter. Even individuals with stress, they develop a support group in which there is little counseling or insight-oriented therapy. So you need to have an expert, a psychologist, a clinical psychologist, or a psychiatrist on board. Then the project will be reviewed as with other project with ERC or IRB, in which some precautions need to be made. Say if you'll take enroll mild to moderate cases. If there's severe cases, somebody has severe symptoms or majorly distressed, then you refer them to a healthcare facility. Somebody could have a serious depression. An individual can be suicidal. Some precautions need to be made. So they will be referred to a psychiatrist, they'll be referred to a physician, or they'll be prescribed some medication, and follow up with a physician would be arranged, as generally happens. So the project will be reviewed by IRB or ERC. And if there's a technical expert in that, then I don't see any problems. You don't need to, and that's even easier than what you're saying. So if you're testing a drug. So if you're doing a drug trial and it's off-label indication, developing a new drug is like takes a lot of years. It takes 10 years, and you have to go through phase one, phase two, phase three trial. So it's a costly endeavor. So the newer angle to mental health research is off-label indications. A lot of drugs are developed and licensed, but they have other indications. Like atypical antipsychotics are a good mood stabilizer. There are compounds, mood stabilizers like sodium valproate, lithium, lamotrigine, and they act as a mood stabilizer in those who have emotional disturbance or mood swings like bipolar disorder. But atypical antipsychotics, the primary indication is treatment of psychosis, but they're good tranquilizers and mood stabilizers. And some atypical antipsychotics are also used as an augmenting agent in treating depression. So these are, or some are used as a sleep-inducing agent, because the classical hypnotics, benzodiazepine, and habit forming. A lot of physicians don't want to prescribe, and patients don't want to take them because it has caught on. Patients come and say, okay, medications are habit forming. We don't want to take hypnotics. So atypical antipsychotics are used as anxiolytics. So there are a lot of off-label indication-based research, and in which you don't need to have like regulatory authority because they're already licensed compounds. So, and scope for that is also huge in terms of its application.
Right. So moving forward with our next point for our discussion is that you touched on this a bit, but I want to talk in detail about this area. That what are the issues specific to mental health research from the perspective of data collection? And as we know, in the like you have to specifically look for the validated tool. So I just want for you to talk about what is a tool, what is a validated tool, and if you do not have a validated tool, how do you proceed with that?
I think it's more important mental health research than other discipline because the outcomes are very hard. Say if you're doing a lab test, if you're doing an MRI, if you're doing some other metric measurement, maybe weight gain, girth or something, BMI. So that's like more objective. But in terms of subjective outcomes, the standardization has to be there. So the training element is very critical in mental health research. As the garbage in, garbage out. The GIGO DOS-based program has this acronym, the GIGO, garbage in, garbage out. So it's most important that the data collectors are trained well and there are standardized procedures And in good training program, as like you have had good experience, AQ was a good institution in terms of epidemiology. The board of graduate studies made sure that they do everything right. So there are standard operating procedures, SOPs for describing, validating, collecting the data. So training has to be right, and you have to use the robust tools. And in terms of collection, then it's how it's collated, how it's stored, and how it's summarized, how it's reviewed, what you do with missing data, and the interpretation. So that it needs to be thought through. It's not that you collect the data and then try to make sense of it. You can do that, but that's bad research. So individual need to think through what information you're going to collect, and it also applies as far as the mental health is concerned. Patient generally disturbed. I mean, you can go back to someone, oh, I missed that. What's your age? Is a patient with hypertension, you can go back. Oh, I'm sorry, I missed that. I didn't collect the ethnicity. Where do you live? What language do you speak? Are you married or not? So you can go back and collect that information, or maybe collect it from personal records. But in terms of mental health, so you have to see the patient is in distress, or his ability to communicate, and some of the information might be confidential. So if you've not thought through, and in terms of tools, if it's not a validated tool, so the construct would not apply. So each language, since it's based on interview, and interview is in an interview you elicit the symptoms that are conceptual equivalent. Each language has its own idiom of distress. Some symptoms, although biology is the same all over the world, but the descriptions are different. And even in within the same country, you have different ethnicities. Pashto speaking patient would say that he has Afghan. Dari would say jigar khoon. Depression is the English term. In Urdu, you will say udasi. So even within the same country, you have four different descriptions. So if the data collector, interviewer is not aware of the background and does not pitch the question well, so really it's you might miss it. So the and that has to do with the validation of the tool, the cultural adaptation and the validation. But it's not that difficult. I mean, if it's a bell-shaped curve, if it's being used in neighboring country, or a similar speaking is being used in India, Bangladesh, then you can safely assume and that culture is mostly the same. So you don't need to do a validation study first and then do the data collection. So you can, there are ways to go around, and if it's been, and thing is, if you use a validated tool, then you also have another study to compare your data to. Because each study is just a point estimate. You want to compare your point estimate to what has been done before. Good literature review of literature, and using the tools that has been used earlier is safer way to compare your data, and then you know that you're not making mistakes with the basics of the research.
Right. And I want to, because this is a very important area, I just want to spend a bit more time on this. You talked about like I got a tool. Let's assume I got a tool in English, but I want to administer in Urdu, right? What normally people do is just like give it to a translator, which is not very much a trained person, and just like get it translated. Is that a good way to do, or you have an alternative suggestion for getting the tools translated for psychiatric research?
Yes, there are specifically defined methods. I mean, there's a very good paper by Athula Somatipala and Vikram Patel. These are London School of Hygiene professors, and they're welcome fellows. So they're trained in clinical disciplinary research. There's a very famous good paper, and points out 8 steps in terms of translation and validation. So rather, getting it from one person is not a foolproof method. Generally, what they say that you should get it translated from at least two, if not three, and then get it back translated. And for example, you have a set of questions: low mood, anhedonia, disturbance, sleep, impairment, hopelessness, suicidal idea, death wishes, or caregiver's burden, that you feel stressed, that you have to do a lot, and then an attendant who's caring for a mentally ill person who has a chronic illness, then do you feel stressed? Do you ignore your usual activities? Have you felt that life is a burden? And then questions about depression. So if you, because the variation is there in terms of the words we use and the language, the nuances of the language, it has to be pitched towards a person who has minimal understanding. So somebody who's just done the intermediate, somebody who's just done the metric or has cleared the grade 5 or grade 6, a common layman person. So the questionnaire needs to be translated in terms of language so that a common person can understand. So if you're going to give it to a librarian or an elite person who has a book on poetry coming out next month, and he's bilingual, or maybe he has command on 6 languages, he might do a very robust translation, but it would not be applicable. So getting two, three, and for that matter, then you have to choose whether they're expert in the field or they're language expert. Sometimes you can get both, that there's an expert on language and there's also a mental health expert. And sometimes you'll get just a language expert. So language expert would translate the idioms into similar words in the same, from the native to the foreign language, but it needs to be pitched at a level where a common person can understand. So in some constructs, say, so there is a questionnaire for measuring depression, SRQ or back depression inventory, and in which a critical aspect is missed. Say anhedonia. Anhedonia is lack of pleasure. Pervasive lack of pleasure is one of the two common symptoms of depression. If you diagnose depression, then person needs to have low mood and anhedonia for last 2 weeks. So anhedonia is a critical symptom. I mean, if you have two, then you diagnose a symptom of depression in terms of clinical and field work. So what would be the equivalent of anhedonia? If that question is translated wrong, and you have 9 other questions that are translated right, so then even missing one, so item wise correlation is important. So even missing one important question or getting it wrong would have an implication of the final score. And score might be like, 21 out of 30. Cutoff is 21. And if you missed one and that is, it has 4 points. So, so you're doing it wrongly. A lot of positive cases would be missed, or wrong would be, or they would be diagnosed wrongly. So that is the reason that you need to have 3 translations and the back translations. So you translate it from English to Urdu and then from Urdu back to English. And then if there is a discrepancy, then you discuss and agree and come up with a word that is near to the original version. And once you do it in your community, then you get the good results.
And I think this is an important opportunity. For example, even in Urdu, there may be some tools, but like in languages like Pashto or Sindhi, there is almost no work done. So this may be an opportunity for young researchers to make their mark. Make their work recognized. What do you agree with this
Yes.
point?
Yes, definitely. And the good thing is, you don't need a larger sample. I mean, sample size, it's a representation of a bigger population. So for validation, you need a small sample studies like 25, 30, 40, and but it needs to be done right. So it's like people shy away from this work because they think it's not important. But in fact, it's the building block. If you get this right, then all the results are relevant, and it's definitely a very open area, or a very incentive based area, that if you work and publish, then say if I have a grant and I want to do it, and I want to collect a sample from the Sindh, then of course I need to translate in the local dialect, and then it needs to be translated into Sindhi. So some psychiatrist who has a native Sindhi background is able to translate those idioms, then I would need to collaborate with them. And if there's a funding and if there's a hiring in it, then I would have to hire someone who understands those nuances. And if he does the translation, then it's morally right for me to recognize that and put him as one of the authors.
Right. And
So yes, I
additionally,
agree. There's a huge prospect.
right. Additionally, if somebody has validated the tool, they can even charge the data collection process for that tool, and it
Yes.
can be a revenue generation process for them to get them incentivized. I mean, is that a
Yes.
correct understanding?
Yes, yes, I totally agree.
Yeah.
And your pressure is, if you, you once you get a grant, the pressure is there to deliver. You have timelines that you need to translate, you need to get an ERC, you need to collect that much of the sample, the first patient coming in, you need to close the data collection.
Right.
So there's a lot of pressure and money is there, but that's an irony. I think you need to sort of focus on that too in your future programs. In fact, the thing is not that that as it stands now, you have a lot of money and international support, but we do not have the researchers. It's not that there no money and there are no career prospects. So there's a huge career prospect and there are a lot of money, and the specialists need to do those things in order to be promoted from basic assistant professor to associate professor, and for that from professors to senior positions. There's a lot of money and incentive attached to discipline and promotions and hiring, um, but there are very few people. So people need to be encouraged to come to research. So it's financially very rewarding.
Right. As we have some questions coming up, and I will like to remind to those who have any questions, it's the time to put them in the comments. We'll be taking them in the end, and I will move forward to our next point. Is you talked a lot about this point. Is that how to? But let's assume I want to start a research work, and I want to focus on making a validated tool. How would you?
Mhm.
Because as we discussed, this in itself will be a separate research project which will have a substantial reward. How would you suggest that I should start planning my work?
I think, and we've discussed that earlier too. I think the important point is getting the research question right. So if I'm planning a research project, then say depression in shift workers, sleep disturbance in sleep worker, anxiety in stress, those who have shift duties or those who work at night or exposed to certain work conditions, long working hours. Um, and once I have the question right, then the next step is how would I measure what I'm saying I would measure. But most people blunder or make a mistake at the level of defining the question. So I think that's a bigger irony, that we collect data and then try to make sense, mostly data mining. So this is where we don't like to discuss with senior colleagues, with other researchers, or do a thorough research literature. So there's a lot of pressure in terms of time, graduating, publishing. So we cut corners and it become like critical. The most important part is defining the question, the research question, the hypothesis. Once that is clear cut, it's cut and dried, then the measurement part comes in. So generally we um, lack clarity on the question and we try to fill it with too many questionnaires. So if I've not defined a question, sleep disturbance and shift work, so I need to define so what am I looking at in particular. So circadian rhythm disturbance or sleep disturbance in terms of number of hours put or early morning awakening, quality of sleep, or work in as such, nature of the work that has an impact on physical health, and then it leads to disturbance of sleep. So because once I'm looking at a specific questionnaire, it might be just description of symptoms, but biology is different. I mean, there are a lot of systems involved. We don't know. A lot of questions are just associations, statistical association between two variables. It does not necessarily explain the biological interplay, whether it's a cortisol or it's a growth hormone or it's just like some intrinsic gene that has a disturbance or a protective factor. So it's most important we define the research question right. Once we get the question right, then instruments are not an issue. Then a lot of work has already been done.
So if I make a question, and some of the time it happens that I went to my supervisor or my boss or somebody else who is supervising my research work, and sometimes the weird thing happens is that I'm given a very non-specific feedback, or I don't know. So the first problem is that I do not know how to take my word to my superior, and then the superiors give a very non-specific feedback. So what suggestion would you give to the researcher and the supervisors?
I think the suggestion once you gave me, I will like turn it back. And you said we need to build a two by two with like good supervisor, bad supervisor, smart student, dumb student. So the worst combination is this bad supervisor, bad student. And
Yeah.
good combination is good student, good supervisor. Or you need to have one of them need to be smart. If you construct a two by two, there has to be discordant and concordant. So,
Hmm.
discordant would work.
Hmm.
I mean, for a student, you need to do the homework. If
Hmm.
you go in and you say, I want to do research in depression, so that's really not very motivating.
Hmm.
So this is what I also tell my students also, or students I'm supervising in non-research and they're following someone else in terms of research, is that do the homework first. So if you do the homework and you've already looked at 8, 9, 10, 12 studies, then pretty much you're looking at work of like 12 research groups or 12 published articles. And if it goes at an unconscious level, then the mind automatically works that you pick things from one study in another area, the limitations, the strengths. So you come up with your own question. If you even review 5, 6 studies. So the blunder that we make is that we don't do the homework, right? And we have a wish list that you want to go into with uh, the consultation room or the meeting and then come out with a fully formed thesis. So it does not happen like that. It's a discourse. And also the other thing is that a lot of like people like me, that era I was trained, research was literally not known. There is a boom of research in last 10 years. Some of us have caught on to the wagon ride. A lot of people have not caught on. And the reason we've caught on is that there's a lot of emphasis in the university that you have to do research, otherwise you will not progress. It's not that we were very intelligent or efficient, but we had to do it. So you would have people who are not very savvy, or they're not they're intelligent otherwise, they know the discipline, but they're not savvy, or they have their own anxieties and hang-ups, so they're not able to guide the student. So there are problems at both the ends. But at the level at the student is that, if you do the homework, even if I'm a supervisor and I'm like half ignorant, but I know that you've done the homework, so I'll be willing to go with you to a point where I develop an understanding. So it's mostly communication and a discourse. So this is what I'm saying. The discourse does not happen. And to bring an analogy of Quran, the whole Quran does not have had not come just once. It has come down in like 23 years on the heart of Prophet, and all the Muslims then follow the teachings of Quran. So something like Quran has not come once. It has come out over the course of many months, years, and then it's like an established book. So it is how it is with the truth. None of us have the whole truth. We have a fragment of truth. If I have an idea and I talk to you, it's literally I'm bouncing ideas with you. You would question, you would, even your expressions, your understanding and insight. Say, you know, we're meeting up on a morning breakfast in cafeteria as we used to, and then there's a competition between cheese omelette and what Dr. Amir is discussing. It's a very tough combination, and I'm hungry. I want to finish this cheese omelette and go to the clinic. But Amir is discussing a clinical trial that needs to be done, an intervention that is delivered through mobile phone. So the expressions, your interest, so that it has to be better than the cheese omelette. So
Hmm.
how you pitch it, okay, there's a huge grant in it that the cheese omelette is good, but so many people are dying because they're not eating. If we deliver this through the mobile, then you're going to save so many lives, and you will be eating two cheese omelets if you do research with me. So it's like your skill, how you get it across to me. And so the discourse is important, the whole idea. And what do you know, even if I've not paid attention, I'm going home at the end of the day, then the thought is still in my mind that what you said, then I will go home and browse that, with this is a very smart student, very smart researcher, Dr. Amir talked up in the morning that it needs to be delivered through mobile phone.
Hmm.
Then I'll see whether he's making sense or not, and then if I do a Google study and someone at Harvard is planning it, then say it's a smart idea. So it's a discourse that needs to be developed. None of us have the fully formed idea. So, and the people you trust, it's not, I'm not saying you discuss it with everyone. I mean, ideas get stolen,
Hmm.
and once it's stolen, it's done so badly that you regret. So people you trust, and you trust them that they're going to encourage you and support your career development, growth, and research. And then it's developed through individual discourse. That has been my observation.
Right. And additionally, I will add the idea should be better than the omelette, but it should also be better than the money generated from the clinical work. I mean, that's also if you are a clinician, and I mean, that should also be, the clinician should be convinced that it is worthwhile his time. Is it's also correct, right?
Yes, I totally agree, and that's not an issue. This is what I'm telling you. The If I don't publish, I will not be promoted. The
Okay.
hallmark of scholarship is research and publication.
Hmm.
Research has to do with critical thinking, reviewing what has been done, writing, collecting the data, and publishing. So I will not be promoted. I will not be appointed. Even the PMC new criteria. Previously, you don't needed a super for appointment of AP. You never needed a paper, but now they're coming up that you need index papers, and PMDC has been revised to PMC. So the criteria for recent publication is going to be like increased. So clinicians are is that they cut corners and they waste critical time. Once the time comes, they're not there. And a lot
Hmm.
of people have they're very intelligent people, and their appointment and promotion is delayed just because they have not paid attention to research. And there's a lot of money in it,
Hmm.
so it definitely in terms of funding. So this also needs to be highlighted that it's a lucrative. It's not that the money goes to your pocket. The money goes to career development, training, patients resource, and literature publications. So you're right. Yes, the financial aspect also needs to be highlighted.
Right. We have a couple of more points before we move towards a couple of questions which we have in the chat. Is that we haven't touched a lot on the qualitative research. So, would you like to highlight the role of qualitative research in mental health?
Qualitative research is where you generate hypotheses. Most of the research, quantitative research, has to do with measuring certain defined terms. So somebody has defined that you have depression. Somebody has defined you have stress, you have somatoform disorder, you have psychosis. That has been defined. But there are a lot of areas in which the theory is not defined, or generating hypothesis related to why something is happening. Why do you have transmission of COVID in a particular subsection or ethnicity or in cities, or what aspect of a city where it's like population is not defined, where there's quarter settlements. So in qualitative research there's a focused group in which there's discussion, and in discussion you generate hypothesis. So this is very central to psychiatry and mental health. And the disciplines that contribute to is like psychology, social sciences, anthropology. They're allied disciplines that focus specific on subgroups or communities. Like substance use addicts have a community. So I was just listening to a video in which somebody, there's a researcher, a lot of behaviors research has come from an animal that they put two rats in two cages, and in one case there is like a narcotic, and the rat goes narcotic, analgesic or something, or heroin. The rat constantly goes to a point and it drinks that fluid in which the narcotics are added, to the point that it kills itself. In another, nothing is placed there, or it's in a sequence that it's available sometime, it's not available at other time. So, and it was proven that if the narcotic is available, the rat will drink to a point where it kills itself. But another researcher, Scandinavian, from Europe, has come in and they've designed a better cages in which it's sort of a rat park. Rats have instruments, it has other item to eat. I mean, there's a she rat and there are a lot of other things. And then they put a drug. So surprisingly, the rat does not go to the drug. It's a huge implication. It's not a drug that an addict is dependent on. It's the life. If you give them the life, if you give them the opportunities, and I've seen it that you admit patients for a month, the moment they go out, they go back to addiction because the society um, looks at them critically, they judge them, and they cannot go back to a place where they're accepted. They have limited work opportunities, the financial stressors, pressures come in, they just cannot cope. So if it's like a rat park where they're not judged and opportunities are given, then they don't need to go back to the addictive substances. So it's based on observation. Observation is based on discussion, and sometimes those discussions are a change in paradigm. It's like just based on this observation or a discussion between few clinicians, you come up with newer hypotheses. Since psychiatry is subjective, so that's why qualitative research is very central. But it's like for quantitatively trained researchers, it's like a jungle of speculation, and desert of information. So a lot of people don't feel. But what we are following is a mixed method. Generally, a lot of researchers in psychology and psychiatry also, they follow mixed method in which the initial part is qualitative, in which they generate hypotheses, test the constructs, the tools, the definitions, and once they come up with a conclusive tool or the construct, then they measure it in a quantitative way. So the mixed method is the way to go forward.
Right. And the final question before we move towards the question answers from the comments is that what do you think about issues specific to ethics of mental health research?
Yes, I think ethics in general is important, but it's since mental health is a vulnerable population, like pregnant females, kids, children, mental health patients are also more at risk, and somehow it's not that they lack the capacity, it's they're more vulnerable in terms of, so I'm wary of parachute research, that people come in, do the research, get the data, and they progress in terms of their career, but there's very little done in terms of, changing the lives or quality of life of a patient. So, so ethics is doubly important in terms of individuals with mental health issues.
Right. So now we will move towards the comments or questions. So this is Dr. Dost Muhammad. He's asking, most of us, especially postgraduate, are mental health research naive and little skills to do. So do you have to say any on this? He's saying that you don't know how to do research. What should he do? I think we lost the signal, or at least there is a break in the signal. Dr. Heather, are you able to hear me? We'll wait till the signals resume. Dr. Heather, were you able to hear the question or read the question? I think there's some connection issues, and we apologize to our viewers. Um, Dr. Heather, are you still with us?
No, I cannot. Most of us are.
Can you hear me? You cannot?
I think Dr. Dost is talking about the skills related to the mental health research.
Yeah, yeah. So what would you suggest to those? His question perhaps is that I do not. I'm a mental health.
Yes, I'm with it. I think the skill part is important, and such forums are important. That this is what we started with. That the COVID has been a tough year, and there are always resources. I mean, Coursera has courses. There are online courses. If you are motivated and interested, and so self-learning is there, and
I think we lost Dr. Heather over here. We'll see if he's able to join us back over here. And what Dr. Heather was alluding was we have a number of resources in the form of Coursera, edX, and Dr. Dost Muhammad or anybody else like that who wants to learn. These days, it's very easy to use these online courses uh, to learn different aspects of research methods. I think, yeah, Dr. Heather is able to join us back. And Dr.
yes,
Heather, I think you lost we lost you, and now can you hear me clearly? Dr. Heather, are you with us? Can you
yeah,
hear
I'm
me?
here.
Okay.
Yeah. There's
So,
issue with the connection. So I
okay.
think
So,
it's the skill part. The skill part has to do with the motivation and training. Yeah, I can hear you. Yeah,
okay. So, we'll move to the next question.
I can hear you. So
Okay.
the
Okay.
skill
Okay.
part has to. Yeah, I can hear you. And the Dr. Dos basically asked about the training part. I think if you have a question in mind and if you want to get an answer, then motivation is an important part. So there are a lot of online resources, and videos and discussion and chat groups, research forums on WhatsApp.
And we apologize, we have lost Dr. Heather again, and we'll move forward with our next question. What is the scope of using technologies as tool of psychological interventions, mobile apps, etc.? Please shed some light on challenges and opportunities. I think as Dr. Heather comes again, we'll put these questions again. I think we are having a bad time with Dr. Heather in terms of our internet connection, and we apologize for this. Uh, uh, we have to wait till Dr. Heather is able to join us again. Um, and we will, if anybody, in the meantime, if anybody of you have any questions, then you can put them in the comments. I'll be taking them. And there's a comment from Imam Naqvi. Thank you for excellent talk on how to develop a research portfolio. What are the typical ethics of mentor? This is, I will also put this question to Dr. Heather when hopefully he is back. Okay, yeah, I think we have Dr. Heather back. Dr. Heather, can you hear me now? Dr. Heather, can you hear me now?
I think Dr. Imama has asked about the ethics of mentor and mentee relationship.
Yes,
Can you hear
yes.
me?
Yeah, I can hear you. You can proceed with answering the question. Dr. Heather, you can proceed if you can hear me. Dr. Heather, can you hear me? So we have lost Dr. Heather again. We do not have any other choice but just to wait for him to join us again on this talk. And in the meantime, if you have any questions, we will be happy to ask Dr. Heather. We apologize for this inconvenience. Um, let's see. Let me see if I'm able to contact him through my phone and see if he can join us back. In the meanwhile, yeah, we are trying to get Dr. Heather connected again. Dr.
Yes,
Heather,
yes.
okay,
I
can you?
think Dr. Imama asked about the ethics of relationship between mentor and mentee.
Yes, yeah.
Back live.
Dr. Heather, I'm not able to hear you clearly. Are you able to hear me?
Can you hear me, Amir?
I can hear you, yes.
I'll give my input. I think it's like the relationship is regulated in the context of a university. Yes, I can hear you. The Dr. Imama has asked about the question of ethics of relationship between research mentor and mentee. I think it's pretty much, you know supervised in the context of a university setting. I mean, it's like in a different context that would vary. But if you're working at a university hospital, so it's like a research office monitors the basic conduct of a supervisor and a supervisee or the mentee. So that's not an issue. But universities or colleges have enlisted individuals established research track.
I don't know what is the problem. We have lost Dr. Heather again, and this is kind of an annoying but I apologize for this. I think we might have to end this live stream here if you're not able to um, continue this conversation. I apologize to those who are watching. We just wait a few minutes. And if we are not able to continue this discussion, we will end this live stream. Let's see if I'm able to contact Dr. Heather through phone. I think Dr. Heather is again online here. Okay, I
I
think the
think we're in
connection.
the last minute.
Yeah. So I think the connection is better if you just want to, uh, if you want to conclude your discussion or you want to say something.
Hmm. Yes, I think the question is about the relationship of a mentor and mentee. Yeah, yeah. It's like I think we're at the last minute. The regarding the last question is generally supervised in the context of a university setting. So it's pretty much established what the supervisor would do or the mentee would do. But definitely in terms of generating hypotheses and supervising a student, the faculty is trained in that. A lot of applications, ethics application, IRB applications are go through supervisor or principal investigator or the supervisor, and student is enlisted as a co-investigator, because there are risks in research as there are risks in clinical discipline. If you do the procedure badly on patient with myocardial infarction or laparoscopic cholecystectomy, the patient would die. So there are also risks with research.
I don't know what is happening in the end. We are having this connection. So I think you'll have to end this conversation. And I'm really thankful to Dr. Heather for giving us time for this. Dr. Heather is again online.
Yeah, yeah.
Yes. Okay.
So I'm sorry. There's a problem with the technology. So there are risks with research, as with clinical practice.
Okay.
So the supervision is like robust in good places, but the culture is not established. So the problem is with the prevalent culture, not with the regulations. Institutions have those policy documents, but they're not implemented in a way. So that's why you see a lot of students writing that they're not giving the due authorship, or they spend critical time, but they're not supervised in a way that they should have finished their work. Places there are problems with the student support also, that students are not supported in terms of their clinical or didactic coursework leading up to the research. So once those aspects are missing, and once they have the free time to collect the data, they do not have the understanding. So I think rather than having a policy document, because those are existent, but the culture is not established. Culture is less of support, and so once you don't have a good support in terms of providing the due diligence or instruments and support or research groups, journal club groups, time, protected time for research. So the culture is a critical part, and it's not implemented in letter and spirit. So students lose the motivation, and the productivity also declines in terms of institutional output. So I think it's an important question, and it's a separate discussion on its own. I mean, if you and you do realize those issues, I
Yeah.
think those are the burning questions. That why we've talked about there's a lot of monetary benefit, there's career to be developed in terms of research, but why few and few people are coming in research, and why a lot of people are disappointed, and despite a lot of advantages. So probably you can do a whole program on that, and it needs to be addressed.
Right. Uh, okay. So with that, if we have time and if the connection is lost, this is a very good question. What is
Anything
the
else, Amir? Dr.
Uh,
Amir?
yes, there's one question. If you have a couple of minutes, do you have a couple of minutes, Doctor Adam, or you want to conclude it?
It was wonderful to be here to talk to you and to answer some of the questions. And
Okay.
I'll say it again that you're doing a wonderful work. And if you need my input on any other occasion, then I'll be more than happy to come again.
Right. Thanks a lot, Dr. Heather, for giving us time on this weekend night. With this, I will say thanks to my participants as well. Take care for the timing. Allah Hafiz and bye.